town tonight. Bravo to everybody who came and wants to talk about an incredibly important, often neglected topic. And I guess it's sort of, when I think about the Rodney Dangerfield of healthcare or something, then I think, well, right, yeah, up against the president's in town today, the Red Sox. But we're actually talking about what needs to be talked about tonight. This is the open classroom, and as you know, welcome to all. We're talking about health policy across the semester every Wednesday night. And this week, as I said, we're going to be talking about the Rodney Dangerfield of health policy, something so important but often neglected, and that's long-term care and the care for people with long-term and persistent needs. In health, it seems to me that in health policy, our first, the picture that usually comes to mind, and so it is around the ACA first, is healthy people who suddenly get acutely ill, right? And that's what our healthcare system has been built around. Sudden, acute encounters. And then, more recently, and this is all to the good, and we've talked about this in the class this semester, we're also beginning to think about prevention and wellness and preventing illnesses and managing chronic illnesses. But again, we've been doing it in a sense, when you talk about wellness, you're still assuming people are primarily well, or we can keep them well. Today we're going to talk about what happens when all that's not true. And we'll talk about the problem of long-term care and other similar needs. We are very pleased to have two very distinguished, fabulous speakers who will be speaking. Immediately to my left is Alice Bonner. She has been a geriatric nurse practitioner, caring for nursing home residents and their families for over 24 years. She's currently an associate professor in the School of Nursing at the Bouvet College of Health Sciences here at Northeastern University, and a faculty associate in the Center for Health Policy at Northeastern. From 2009 to 2011, Dr. Bonner was the director of the Bureau of Healthcare Safety and Quality, including the state survey agency at the Massachusetts Department of Public Health. And from 2011 to 2013, she was the director of the Division of Nursing Homes in the Center for Clinical Standards and Quality within the Center for Medicare and Medicaid Services. And she currently serves as a consultant to CMS. While at CMS, Dr. Bonner co-chaired an initiative that developed and implemented the National Partnership to Improve Dementia Care and Reduce Unnecessary Antipsychotic Medications in Nursing Homes. This public-private campaign established coalitions in every state and continues to work towards ensuring that person-centered, individualized, comprehensive dementia care is the standard of care in nursing homes. We are thrilled that she'll be speaking to us. After she'll be speaking, to her left is Bob Masters. Dr. Masters is the Chief Executive Officer of the Commonwealth Care Alliance, a nonprofit prepaid Medicare and Medicaid financed care system that provides care for thousands of medicated dual-eligible elders and younger individuals with disabilities through multidisciplinary primary care teams in 25 primary care sites in Massachusetts' low-income communities. He's also a practicing physician, board-certified in internal medicine, with over 30 years of experience in the clinical management of patients with advanced chronic illness and disability. In 2009, Dr. Master was recognized by the National Committee for Quality Assurance with a National Health Quality Award for his leadership in improving the care of vulnerable populations. Prior to his role at Commonwealth Care Alliance, Dr. Master served as the medical director of the Massachusetts Medicaid program in the Dukakis administration, where he was responsible for all programs, policies, and external relations of the Medicaid program. Until 1985, he was the first physician and medical director of Upham's Corners Health Center and founder of the Urban Medical Group in Boston, where new approaches to nursing home and home medical care using nurse practitioners were defined. Approaches that transferred hospital-level services to the home and the community. So we're really pleased to have both of our speakers. We'll have questions and answers after their presentations. Thank you.
I was going to say, you know, you had Obama here, you got the Red Sox, you've got us, so it's the big three. But the other thing I just wanted to say is I'm just so delighted to be presenting with Bob Master, who's somebody who I've known for 20 years, and because of some of the really pioneering work that he's done with nurse practitioners and physician teams. So for me, it's kind of like presenting with Yoda. So I'm really glad to be here. John Auerbach and I just had a delightful time with a group of students who meet right before this class. And we had a very lively exchange, and they had fantastic ideas, and we really want to keep that going. So even though we're going to talk, you know, I'm going to talk for about 40 minutes, and Dr. Master's going to talk for a while. If there's a burning question that you don't think we're answering, either write it down so you can ask it at the, 20 minutes that we've left for Q&A, or if you just have to get the answer, please ask. We'll keep this informal. This is a nice small group. And we really want to hear your ideas about this, because it's going to take everybody to solve the problem of long-term services and supports for all of us. We're going to have to do that together. So one of the concepts that I just wanted you to think about as we're going through the program tonight is, if we say to be or not to be, home, what does home mean to you? That's a really important question, because we're talking a lot about being home or in some sort of residential care. And so there's different pictures of homes here. Maybe you think of a home as a house, maybe it's a high-rise, maybe it's a trailer. Maybe there's people in this audience who don't have a home, who live in a shelter. Not everyone has a home. So when we talk about long-term services and supports for everyone in society, that concept of home turns out to be really important. So here's some of the things that we wanted to do this evening with you. We wanted to look at our current system of financing and incentives for long-term care services and supports. We wanted to think about the different levers. What are the policy levers that we can pull to make change, to influence our ability to deliver high-quality, cost-effective care, whether it's in the home or in an institution. And we wanted to talk about the concept of choice. So, Americans in particular have a very strong desire to be the makers of their own destiny and have choice in the decisions about their health care and about how they live their lives. So for a lot of people, if you ask older adults where they want to be, they will say in their own home. But for some people, some sort of residential or congregate living setting is something they're interested in as well. So how do we do this? So the first question is, what do we mean when we say long-term services and support? Well, 12 million Americans have some sort of functional impairments, and those are the people who rely on long-term services and supports, either in their home or in an institution. And so that means assistance to people who have these functional or cognitive limitations to help them perform what we call activities of daily living, getting dressed, taking a bath, getting their food, eating, etc. So people get supports from various places. They might have family members, unpaid caregivers who might have to give up a job or care of other family members in order to take care of someone who's frail and needs a lot of care. So it can be informal family members. It could be paid caregivers in any setting. So people who work in nursing homes, people who work in community care. And a little over half of these people are over 65, but also, 44% are under 65. So this is a picture of a graph of those, 12 million people. And if you look at the graph where it says 6.7 million elderly, you'll notice those bottom three bars are where people are getting care in the community. So 80% of people are receiving care, long-term services and supports are receiving it in the community. And also for the working age, it's even a little bit higher percentage. And then there are some children thrown in there as well. So some of the things to think about and talk about tonight, long-term services and supports are costly in all of these different ways. Unpaid caregivers who sacrifice in order to be able to provide that care. Paid care is expensive, whether it's in the home or in a nursing home. Nursing homes in the United States cost about $70,000 per year. Assisted living is about half that. And 2/3 of the cost of these long-term services and supports are paid for by Medicaid. So here's a picture showing you that 2/3 from Medicaid, and then you have, other payers, out-of-pocket, private, and other public sources to cover long-term services. So again, it's one of the things that's important and sometimes confusing is when you think about a nursing home or home care, there's actually different payers, and not all of it is long-term care. So there's something we call post-acute care or sometimes skilled nursing care, and this is when someone, as Wendy was saying, they go into the hospital, there's some sort of acute event, and then they go to a skilled nursing center for rehabilitation or for short-term nursing care. That's actually paid for by Medicare, and that's a short-term benefit for a period of months, very often just a few days, and so that's under Part A for Medicare. Medicare also pays for some short-term benefits in home care. So if you come home from the skilled nursing facility or the hospital and you need a short period of time and there's certain nursing needs, you need to have your blood pressure checked, something about monitoring your medications, those can all be paid for by Medicare. Medicaid is what covers long-term services and supports over time. And previously, Medicaid only covered nursing home to provide that care. Over the last 10+ years, there's been a lot more movement toward these alternatives that Dr. Master is going to talk about later on, and that varies a lot by state. So I'll show you some data on that as well. And then there's private long-term care insurance, but not very many people have that, and there are fewer and fewer plans out there. So this is an important slide for our discussion, which is showing you over time since 1995 how much more of long-term services and support is now being delivered in the community. So in 95, 80% of Medicaid spending on long-term care was on institutional care, and you can see that rebalancing, whereas now it's almost a 50-50 split in terms of where Medicaid expenditures are. Another important aspect to this sort of discussion is that this is not evenly distributed throughout the population. So some people require a lot of long-term care services and supports, and other people not very much. So this on the left is showing you that 31% of the population may not need any long-term services and supports, but 20% is going to require that for 5 years or more, and another 20% for 2 to 5 years. And then the other chart is showing you that the expenses are also not evenly divided. So for 50% of the population, there's no cost, but for 6% of the population, it's costing $100,000 or more for the rest of that person's life for them to receive long-term services and support. So again, it's not equally distributed throughout the population. Smaller number of people require more services and cost more. The direct care workforce is an important topic for us to be thinking about and talking about in this discussion, because it appears through many studies that there's going to be a significant deficit in the people to provide this care in any setting. So 48% increased demand over the next decade in the need for home health aides, personal care aides, and independent providers, all of whom provide care in the community. And 37% of the nursing assistants make up this direct care workforce, and we're going to have a need for nursing assistants in nursing homes as well. Part of the problem we have with this workforce, there's many problems with this workforce. They have received very low wages, very poor benefits, but there's also very high turnover. So even when we get people to go into this as a profession, there's very often a lot of turnover. So we need to think about how are we going to develop a workforce of people who have the training, the skills, and the heart to do this work, because this is very hard work. Again, Dr. Master is going to talk about a number of these alternatives to the nursing home, so you'll hear about some of the ways different states are being creative and flexible and applying some of the waiver programs. But in order to set the context for that discussion, the question is, so what is a nursing home? We have to have a common definition. So let me give you a few definitions of what is a nursing home, what's a skilled nursing facility, and what's assisted living. So a nursing home is also called a nursing facility. That's in the regulation. And this is a facility that's licensed by the state to offer residents personal care as well as the availability of skilled nursing care on a 24-hour basis. So room and board is covered in a nursing facility, supervision, medication management, some therapy and rehabilitation if you qualify, and the rooms are often shared. So in Massachusetts we have 2, 3, and 4 bed rooms, beds to a room in our nursing facilities. And there's generally communal dining. And a lot of the people in these long-term facilities have some sort of cognitive impairment. So within that kind of facility, sometimes one wing or one part is designated as a skilled nursing facility, or the entire facility could be certified as a skilled nursing facility. And this is called a SNF, and it's a facility that's licensed by the state and certified by Medicare to provide 24-hour nursing care and rehab services in addition to other medical services. So again, the post-acute care or SNF care is covered by Medicare, and these units can be part of a larger facility. So in terms of thinking about the nursing staff in these places and what does that entail, the only federal regulation says that the facility must have sufficient staff on a 24-hour basis to provide nursing care to all residents. And the regulations, the federal regulations further say a licensed nurse, which is very often a licensed practical nurse, someone with about 10 months of training, has to be there on each shift or each tour of duty. A registered nurse has to be there for 8 consecutive hours, 7 days a week. That's really minimal. And a director of nursing must be a registered nurse, so must have a certain level of training. These are very minimal requirements for the acuity of the people that we see in skilled nursing facilities today, but that's all that we have in the federal regulations. Some states go beyond that. Some states have higher requirements. So if that's what a nursing home is and a skilled nursing facility, what's assisted living? Assisted living is much more of a home with services, whereas a skilled nursing facility is a nursing facility, which is more like a medical or healthcare setting. So assisted living emphasizes privacy and choice. Very often the units have their own bathroom. They lock. You can't lock the door in a nursing home of your room. You can't lock it. You can't lock your bathroom. But in assisted living, very often you can. Personal services are available 24 hours a day. So if you need extra help with bathing or shopping, things like that, you may end up paying extra for certain services. But the only requirement in most states is that there be a 24-hour awake provider. So it doesn't say a nurse, it literally says awake provider. The other thing that's really important is assisted living is not regulated by the federal government. Nursing homes are, hospitals are, home health, but assisted living is only regulated by the state. So it varies a lot state to state, and there's a strong desire to make this a social model and not a medical model. So that's one of the reasons why there's been a lot of resistance to more regulation. We can certainly talk about that. There may be places where if you have memory impairment, they have special units for people who have cognitive impairment. And then there's a variety of other types of residential and other scenarios in the community. They're called things like board and care homes. There's adult day help, so someone goes out during the day and comes back to their family care at night. Congregate housing and continuing care retirement communities, the bottom of the slide, which is where you have multiple levels. So you might have a skilled nursing facility, an assisted living, and independent, and as your needs change, you move between those levels of care. We were just hearing some interesting conversation about, in Canada, some models that are like that as well, some of which are subsidized. So when you hear the word nursing home, you need to, in your mind, remember there's two very distinct populations. There's the people who go there short term, they're younger, they're gonna go home again, it's always in the plan, they're just there for rehab. And then there's people who are there long term and it's actually their home. So what else do you wanna know about nursing homes? Well, you might wanna know how many there are. Well, there's about 15,000 now in the US, and those numbers have steadily been declining since about 2002. So again, 15,600 or so. We had a pretty dramatic decrease from 2002 to 2007, and now a slower decrease. And mostly it's the smaller facilities that are no longer in the marketplace, but also some other trends, fewer not-for-profits and government facilities. So a lot of the county nursing homes have closed. So now 70% of nursing homes are for-profit. So again, you can see it on this graph. Those blue segments at the top that are narrowing show you that there's fewer not-for-profits and fewer government facilities, more for-profit nursing homes. So something else that's interesting is that it's not the same in every state. So depending on what state you live in, you might have a much higher chance of winding up in a for-profit nursing home. So if you live in the South, if you live in the West, the dark blue there, those states have a much higher percentage of for-profit nursing homes. Well, who are the people who live in nursing homes? 1.4 million people live in nursing homes, 2.9% of the over 65 population, but over 10% of the over 85 population, which you would anticipate there's more functional and cognitive impairment. And altogether, about 3 million people cycle through nursing homes, so that includes the post-acute people as well. Racial and ethnic diversity in nursing homes is about the same as what we would see in the general population, not a big change there, but 3/4 of the population in nursing homes are women, so that's higher than we would see in that over 65 and over 85 population, and the majority are widowed. So again, which state you live in might make a difference in terms of whether you live in the community or in a nursing home. So again, the dark blue states have a higher percentage of people over 65 living in nursing homes, and that may have to do with these waiver programs and other alternatives that you're going to hear about later on, and whether or not the state you live in has as many opportunities. It could be because of other factors as well. So what about the functional and cognitive impairments in people in nursing homes? You might think that, people living in nursing homes would have severe impairment, either cognitive impairment or they need, almost total care with all of their activities of daily living. Well, it turns out that about 20% have no impairments in ADLs and 35% have only mild cognitive impairment. So this chart is showing you that data in a slightly different way. And it's possible that some of the people in this category are those short-termers who are just cycling through the system. But I think it's interesting because it's telling us that there are people in nursing homes who have almost no cognitive impairment, almost no functional impairment. And those are people we really want to make sure have the opportunity, if they want it, to return back to the community. So they are there. The 15.9%, I don't think would surprise any of us. So again, why are some of these people in nursing homes? Why are more people in nursing homes in some states than others? And what leads people to live for a long time in a nursing home as opposed to the community? Well, as we said, it's usually following a hospitalization. Very often these scenarios are very rushed. So, somebody falls and breaks their hip, they wind up in the hospital. It's 4 o'clock on a Friday afternoon, and they call up, Mrs. Jones's daughter and say, your mom's going out to the skilled nursing facility this afternoon. And Mrs. Jones's daughter says, but I'm at work, and I don't even know where you're sending her. And, we didn't talk about this. I thought she wasn't going to go till next week. And the hospital says, well, she's going to go today. She's ready, and, she's going to go to this nursing home. Or, there's only beds at these 2 nursing homes. And so that's very often the typical scenario. So we don't do a good job coordinating care. We don't do a good job communicating with families. It often feels very surprising when it happens. And even though we can take care of a lot of high-tech, very complicated people in the home now, so we can have people on breathing machines or ventilators. We can have people getting hemodialysis. We can do all that. It's hard to do quickly. So if someone is leaving the hospital quickly, very often they still need to go to that skilled rehabilitation in the short term, the way we have our system set up now. And again, you're going to hear about states that are really doing innovative things to get even these most complex people directly home. It can be done. We're just not really set up well to do it now in most states. So that's why historically a lot of people have wound up in nursing homes. And then what happens is maybe they get rehabilitation. Maybe something bad happens and they get an infection, or they get a pressure ulcer, a bed sore. And so their rehabilitation doesn't progress really well. And then a month's gone by, 2 months have gone by, they're still kind of weak, maybe they fell, and now people are saying, we're worried, we don't think you're going to be able to take care of yourself at home, so now your Medicare benefits ended, and we're going to recommend that you stay in the nursing home long term. And that's what happens to a lot of folks. Now, that person might get better. They might get better 3 months from then. And that's part of what happened in some of the work on the Olmstead Act and really making sure that we're enforcing the Olmstead Act and some of the money follows the person work as well that you'll hear about. Is there's now much stricter regulations about asking people on a regular basis, if they live in a nursing home, the nursing home has to go back and ask them again and again and again every quarter whether or not they feel like they want to go back to the community to make sure, because we just haven't done a really good job. We haven't had the ability in a lot of communities to be able to make that happen. The other thing, as we said before, is Medicaid used to be more or less the only way that you could, the only thing they would pay for was a nursing home, and now a lot of that's changed. And finally, a lot of the people in the medical profession, in healthcare, just, we want people to be safe. We're very paternalistic, nurses and physicians, and so we want people to be safe, and sometimes it felt like the safest thing was a nursing home, and there would be people who live in nursing homes who would say, I would have felt like I was safer at home or thought I might be safer at home. So what are some of the barriers still? What are some of the major things to be thinking about? Well, transportation is a big one. A lot of people cannot go home if they don't drive anymore unless they have good transportation. I had the opportunity, I was in Washington, D.C. this weekend at a conference and heard a presentation. It was the Consumer Voice conference. A presentation by two women who had lived in nursing homes, one of them for years and the other for over 10 months. And they had worked with case managers to be able to get back home to the community. So they were now living in their own homes. One woman had multiple sclerosis and the other woman had had a stroke, and they never thought they'd be able to go home again. But one of the things they said in their presentation that they found was really important was they could not go home until their transportation was all set. They had to have that fixed, and they had to know that for $37 a month, they would get 10 round trips to either the grocery store or the doctor's office or whatever. So transportation is really important. Accessible housing is really important. People have to have a place that they can call home where they can get out easily and it is adapted to their needs. And Meals on Wheels, there was a recent article in Health Affairs Journal by Vince Moore and colleagues over at Brown showing that of all the things that might be associated with a delay in nursing home placement, with keeping people in the community, that just providing Meals on Wheels was one of the things that seemed to be a strong factor. Behavioral and mental health services are important. And what if someone needs a personal care attendant for 24 hours a day? So they can't get up on their own. They need one or two people or a person and a mechanical lift to get them out of bed safely. So if you're going home and you need that 24-hour care and somebody doesn't show up on that 11 to 7 shift, that we have to figure that piece out so that there's always a backup. A family member can come, somebody else can come, because that's one of the things that when you're coordinating somebody moving back to the community, there has to be a backup so that those things happen. Your home health aide or your personal care attendant, her child could be sick, and she would have to not show up that evening. It does happen. So those things all need to be in place, and people who've been living in a nursing home for years need to acquire some skills for living independently, so that has to be done as well. So all of these things are the pre-discharge assessment, coordinating all of this. If I'm of working age and I want to go back to working, I might need adaptive equipment. I might need a motorized wheelchair or something, and so putting all of this together requires a lot of coordination. And then, as I said, enforcing this regulation that requires nursing homes to ask people about whether they want to go home, and having peer mentors. What I loved about this presentation was these women are part of a group in Maryland that they now go into nursing homes to help people who want to go home, and they help them figure out how. They were really dynamic, and they were really impressive. So these things are changing. We now, again, through the Money Follows the Person and some of the other waiver programs, have transition coordinators. So these are people designated in the state to actually work through these aging and disability resource centers, or with your ombudsman, which is the program through what used to be the Agency on Aging. Now we call it the Agency for Community Living, which was a big part of this, to make this about community living. But there are people who just help folks get back to the community. We don't always fund these programs as much as we could. So that's kind of the backdrop. So what are the policy levers? If we wanted to do this even better, or do it better, what would be the policy levers? So there's different things I know you've talked about in these classes. One of the things is, a statute, changing the law. So legislatively, the Olmstead Act is not new. It's from back in 1999. And this was, people with disabilities have the right to live in the most integrated setting. And the states are responsible for making sure that those resources exist so that people can live in the community if they choose to. So the state of Delaware actually was sued by the Department of Justice for failure to uphold the Olmstead Act. The Department of Justice won the lawsuit, and so the state of Delaware had to put a lot of additional money into certain programs to be able to do a better job in the integrated care setting. So they now have some state rental programs for housing. They had another bill passed that designates a particular person for home and community-based waiver ombudsman work. So again, getting people into the community. So there's just been a lot more around enforcement of the Olmstead Act in the last several years. And again, we talked about the regulatory lever, making sure that people have that opportunity. So what about financing and incentives? That's another regulatory lever. Let's change the financing so that we don't say Medicaid will only pay for a nursing home if you need that level of service, but Medicaid will have all these innovative programs in the states, and we'll test them through demonstrations to see how they work. And so that's these waiver programs, Money Follows the Person. Medicaid managed care is where we get a lot more people who are Medicaid eligible and have a lot of care needs into a managed care plan. And so again, there can be some management of the cost and the services. So all of these are redistributing the resources to the community. And then what's another lever? Well, we could do some things with the workforce. So we could make sure that people in the workforce, that we think about programs to enhance that workforce, better training, better support, figure out why the turnover rate is so high. It's a really hard job, and it's very isolating when you're working just one-on-one with someone in the community. You don't have colleagues and people to talk with, so what can we do about that? Another lever is advocacy, like these women who are doing peer mentoring, and then we've got public reporting. So AARP and the Commonwealth Fund and other groups put out report cards that say, how well is your state doing compared to other states? So sometimes public reporting will embarrass someone to doing, or a state or agency to do a better job. So again, just a couple of examples from 2 states that are doing some really creative things with these waivers. In Ohio, they took 75 independent apartments that people who had really complex needs couldn't live in, and they took the funding and they turned them into assisted living apartments, and they co-located primary care teams so that they had health care right there. And they also had some tax credits for adult day health. So the nice thing about a lot of these waiver programs is it gives individual states the option of being creative in what they think works in Ohio. In Georgia, the SOURCE program stands for Service Options Using Resources in a Community Environment, catchy name. And this is for frail elders and people with disabilities, and it's again about integrating medical care, other services, and looking at health outcomes to prevent unnecessary hospitalization. So there's a savings if people don't wind up in the nursing home or the hospital, and they can use those savings in the community. So this is all about individualized care planning so that the person themselves is directing what they want to happen for them, and it can include a variety of different kinds of supports that you see on this slide. So the question about programs like this program in Ohio and the program in Georgia is, can those be expanded nationally? And does it make sense to do that, or do we want these programs to continue to sort of be state-based? And you know, you look at a program that works really well, people get good quality care, it saves money, and there's a temptation to sort of federalize it, and that's really a question, I think, for discussion. But you've probably heard about patient-centered medical homes or neighborhoods, and those are the kinds of programs that we're seeing crop up that have these same elements of care coordination, better management of care, better management of costs. So most people think that over time this trend to see fewer and fewer nursing homes is probably going to continue. For one thing, if I were to ask here how many of you would like to go to a nursing home, I don't see any hands. So, you know, it's very often the case that people have an impression in their mind of nursing homes that may or may not be true, but nevertheless, it may be their impression that they don't want to go to a nursing home. People who have experience with nursing homes can share very positive experiences, but historically in the press, it's been a place where people have thought that they won't have their privacy, they won't have their things, they won't have a lot of space, etc. So people need options. There need to be options in the community, there need to be options in some sort of residential setting, but I think we might want to talk a little bit about transforming nursing homes. So if you could imagine that you needed the kind of care that today we deliver in a nursing home, so you need intravenous antibiotics and other intravenous medications, you need somebody there 24/7 because you need 2 people to get you out of bed. You need therapy, a couple of hours a day, really intensive services. Maybe you want to be able to receive those services in your home, but maybe you want to have other people around you, or you like that kind of collegial environment. When we were talking in the class, somebody said, it sounds like one of our dorms at Northeastern, you know, when you talk about people living together. So, you know, what would it look like, and how would we get there, and how would we pay for it? Those are all the questions on the table. So the how would we get there, we have the same policy levers that we were talking about before in terms of how we make nursing homes good places, how we make assisted living facilities good, safe places. We have legislation and regulation, public reporting, quality improvement, and others. So in terms of nursing home regulation, just a little bit of background, when you think about nursing homes, we have something called OBRA 87, which is the Nursing Home Reform Law. And before 1987, we had almost no regulations of nursing homes. So there were a lot of quality problems. OBRA 87 gave us the ability, actually a requirement, for every nursing home to do a comprehensive assessment when people come in, has to be reported to the federal government, it's required for payment, and it's, again, a very good clinical assessment. So that was one big change with OBRA. We also now do annual surveys or inspections of nursing homes, and the surveyors also go out on complaint investigations. So every single state must have a way that you can report a complaint about a nursing home, and someone from the state agency will go and inspect and determine if the complaint is valid. So we can find nursing homes that are not in compliance with the Medicare participation. We can, we can have them write us a plan of correction, how they're going to fix the problems, and ultimately we can terminate them from the Medicare program. So those are all important enforcement actions. The heart of OBRA and the Nursing Home Reform Law is that nursing homes must provide care and services that enable every resident to attain or maintain the highest practicable physical, mental, and psychosocial well-being. We cannot have people go into nursing homes and get them up to a wheelchair in the morning and have them just sitting at the nurse's station all day. That's not what our regulations say. We cannot have people left in bed all day. So the regulations give us that minimum standard. And before that we had very little, and we haven't really changed it much until the Affordable Care Act. We also have public reporting in nursing homes, and this is very important. So we have quality measures, staffing measures, the scores on the state inspections, and then an overall score. And I wanted to show you this website. So I don't know if you've been on here or not, but this is Nursing Home Compare. There's also Hospital Compare and Home Health Compare. These are your federal websites that you can put in the name of any nursing home, or you can put in a zip code if you want to look around at a bunch of nursing homes, and it will tell you all the information that we have available about that nursing home. So, and it's been designed by consumers, by end users, so hopefully it's pretty easy to navigate. But if you went to the quality measure page, you would see for every nursing home in the country what their quality is on 17 different measures. This is about vaccination. So for this particular nursing home, you can see they're a little bit higher than the state average and the national average, and it gives you a system of 4 out of 5 stars for their quality measures. So quality reporting is important. And so what we've done with quality measures over the years is we've measured lots of different things. And so, you know, there's been some research to suggest that it's effective in driving improvements in quality, and restraints. Physical restraints is an example of that. So when I started out as a nursing assistant in a nursing home 30 years ago, the restraint rate in this country was between 30 and 45%. That means almost half of the people in nursing homes had a physical restraint, a vest or a belt or something that tied them in it. I was taught to tie people in a chair when I first started. Now the restraint rate nationally is 2.2%, so it's a huge shift over many years. Pressure ulcers, way down. What we're working on right now, which Wendy mentioned in the introduction, is the use of antipsychotic medications, which in a number of cases are being used as a chemical restraint instead of a physical restraint. So 1 out of 4 residents in this country in nursing homes is receiving an antipsychotic medication. Now, some of those people have a legitimate diagnosis, schizophrenia, something for which the medication is absolutely indicated. But a large percentage of these people only have a diagnosis of dementia, and they have no other psychiatric diagnosis, or they have no appropriate indication. We don't give people an antipsychotic medication in nursing homes because they're wandering. We don't do that. We don't give them a medication because they're trying to get up unassisted. But there are places where that happens, and so there was a report by the Inspector General and others, and we identified these problems. Also, there was a black box warning which, you know, says that there's increased mortality in people with dementia when they're given an antipsychotic, particularly, you know, when they don't need it. So CMS started something called the National Partnership to Improve Dementia Care, and this is, you know, we have coalitions now in every state working with every nursing home to say, you know, what is your rate of antipsychotic use? What should it be? How can we help you to use non-pharmacologic interventions, different approaches, understanding that when someone with dementia goes like this because they don't want to take a bath, it doesn't mean they're psychotic. It means they don't want to take a bath, and you haven't figured out nursing home advocate, and she tells the story that when she was really sick 10 years ago, she was placed on an antipsychotic appropriately, and you know, she was in the nursing home for many years, and she finally asked the doctor about what drug she was on, and she said, "Why am I on that antipsychotic?" And he said, "I thought it made you better. I thought you wanted to be on that medication." And she said, "No, I don't want to be on that medication. I don't have any reason to be on that." So he took her off of the medication, and she's been doing much better. And she, you know, but she has a PhD in French literature, so she can advocate for herself. She does this work. Think of all the people, the 1.4 million people, and the 1 out of 4 who are on an antipsychotic who cannot advocate for themselves. So that's why quality improvement programs and public reporting are really important. So here's another one of those distribution maps. And again, it turns out the part of the country you live in is associated with whether or not you're likely to be on an antipsychotic. So if you live in the South, you're more likely to be on an antipsychotic. In fact, the rates there are much higher. We don't know why. So this is just showing you that dotted red line. vertical line is when we started this initiative, so you can see the rates were the same or going up. They were pretty much leveled off, but prior to that had been going up. And then after the initiative, the most recent data, you can see they've been trending down. You can see on this graph, this is just all the different regions of the country, and it's just showing you there's been more improvement in some areas than others, but every part of the country has gotten behind this. So a lot of work in nursing homes. So my point is, it is possible to transform things in nursing homes. It is possible to do things to make them better, and we really have a lot to do to completely transform, how people get care in nursing homes. And even if we're going to have a lot more people living in the community through these programs, we still have to make sure in any setting that people are safe and that they're getting the right care. And we do that through survey and certification and your state agencies. So there's a lot of directions for future research. We could look at community support. We talked about workforce pay for performance, the regulatory system, and this is a gentleman with ALS, so keeping people in the community very often depends on technology. But in summary, these changes are happening, the rebalancing is happening, which is critical. The population is aging rapidly, particularly people over 85. We have to continue to think about this together so we have good solutions. These are a couple of videos. I don't think we're going to have time to show them, but go Sox. And with that, I'm going to turn it over to Dr. Master to talk about all these great alternatives.